Welcome to the VASCERN webinar about genetics and lymphedema. My name is Pernille Henriksen and I am a patient advocate in the working group of pediatric and primary lymphedema. I have the pleasure today to be with Professor Sahar Mansour, who is from the St. George's NHS University Hospital in London, and Carina Mainka, who is the mother of a child with KIF11 and is the chair of Patient Association KIF11 Kids in Germany. Just a few general instructions. This webinar will be recorded and you will be able to watch it later again on the YouTube channel, the VASCERN YouTube channel. All the questions, please ask them in the Q&A box and we will take them at the end. There will be a small delay of about 15 to 20 seconds, so please be patient. And if you have any technical problems, just write in the Q&A box or send an email to our coordination team who will take care of it. Just a small disclaimer to say that the information provided in this webinar is not intended to replace professional healthcare advice and patients must consult with a qualified physician for any diagnosis and treatment. So just a little bit of background about what is VASCERN. So VASCERN is one of the 24 European reference networks for rare diseases, and the VASCERN is the reference network for rare multisystemic vascular diseases, where primary lymphedema is one of them. We are about 70 patient organizations from across Europe represented in this reference network. And we also have the healthcare providers, we have the affiliated partners, and they are from 19 European countries. So we are really well represented in this reference network. And so out of the we are six working groups for different rare diseases, and one of them is for pediatric and primary lymphedema. And now I will present you again to the Professor Sahar Mansour and Carina Mainka, who has pre-recorded the next part. And then hopefully you will get lots of your questions answered. And then if not, then as I said before, you can ask them all at the end in the Q&A or along the way, and then we will take them at the end. Thank you.
Thank you very much for your time, Sahar. So thank you for taking time for the patients today, trying to make the genetics as simple as possible for all primary lymphedema patients out there. My name is Carina. I'm a mother from a 6-year-old child called Paul. I will tell a little bit about our history in a minute, but Sahar, for those people who don't know you yet, maybe would you like to introduce yourself? That would be very helpful. I know that you are a very famous person in the lymphedema world.
I'm Sahar Mansour. I'm a clinical geneticist. I work in London in St. George's Hospital, and I have an interest in primary lymphedema because we have a large clinic run at St. George's Hospital for primary lymphedema. Yeah, thank you.
Thank you. Before we start with very detailed questions about the genetics, I would like to share our personal story, where we come from as a family, and throughout 2 different sessions, we will always come back to our story, to use that as an example. So the whole webinar will be split up into 2 sessions. The first one will be where we will discuss Sahar will show you the basics of the genetic, the different medical terms, etc. And then in session 2, we will talk about the procedure of the testing and how the genetic can help us in the future, and how research can help us as a primary lymphedema patient. So yeah, Our story started in 2016 when I was pregnant with our now six-year-old son. And even before birth, it was clear that something might be wrong. So his head seems to be very small, too small. But at that time, nobody worried about that because, yeah, there are kids with just small heads. So the clinicians told us not to worry about that. But then when he was born, the swollen feet were immediately visible, and that they directly came into my heart, to be honest. But even at that point, the clinicians said we don't have to worry because that will go away on its own. A year later, we knew that this was wrong and that it will not go away on its own. So it took us nearly 1 year to get the correct diagnosis of primary lymphedema. But luckily, shortly after the birth, a clinician sent us over to the genetic testing due to the primary lymphedema and the small head. So those two symptoms were very obvious, and that was then the reason for us to do the genetic testing. And so shortly before his first birthday, then we finally received the results, and the results are called KIF11. So by that day, we had a name for the diagnosis, but to be honest, not pretty much changed in our everyday life. So it was the same kid with the same symptoms. Now knowing that KIF11 is the genetic cause for all that. But looking back, I'm very happy to have the genetic reason. For example, for many social insurances and also for for medical reasons. So I'm happy. So now I'm having a KIF11 child, and I hope we can motivate other patients and caregivers to do genetic research where possible. Sahar, I would directly start with some very basic questions. I know the whole genetic world is very complex for us, for normal people not studying the genetics. Would you mind starting at the very scratch, explaining us some medical terms like genes, chromosomes, DNA? That would be very helpful for us. Thank you.
It's a pleasure. I thought it'd be easier to show you on some slides rather than just talking through it. So we've just prepared a couple of slides, which won't change. Here we go. So in nearly all the cells in our body, we have a nucleus, and the nucleus is where the chromosomes live. So everybody has 46 chromosomes in nearly every cell in the body. And these are packages of genes. So there are thousands of genes on each chromosome. And the genes are the blueprint for who we are. So the genes determine our height, the color of our eyes, the size of our ears, how long your little finger is. Every little thing is determined by these genes. There is lots and lots of DNA that doesn't code for genes, but then there are segments of DNA that code for a gene, which then codes for a protein, which usually has an important role in the formation of your body. And these genes have different effects. So we've known for some time that in lymphedema, sometimes you have a family history of lymphedema. So here is a father and daughter, both born with swelling of their feet because they have Milroy disease. And this is a genetic condition. It can be passed from parent to child. So it's very clear that some forms of lymphedema are hereditary.
Okay. So if somebody's in my family do have primary lymphedema, then it's most likely to get it, to pass it on.
So there are different modes of inheritance, Carina. So the one for Milroy's, for example, is autosomal dominant, which means that you have an affected parent. And then each child has a 50% risk of inheriting the faulty gene. It doesn't matter if they're male or female. You only need one faulty gene to have the problem. So this is autosomal dominant inheritance, like Milroy disease. Yeah.
But I understood that there are different ways. So that's then the risk of 50% that my child will have the defect as well, right?
Yeah, that's in a dominant condition.
Dominant condition, and then.
Yeah. So for example, Paul, he has a mistake in KIF11,
which is then gene KIF11.
Gene KIF11.
KIF11, yeah.
And that's a dominant condition, but like any genetic fault, it has to start somewhere. So he hasn't inherited it, but he could pass it on to his children once he's got it. Yeah.
So from our personal history, so none of us, neither my husband or I, passed it on to Paul. So, hey, surprise. But now when he thinks about his own family planning, then he will be exactly on that chart. He will be the male bringing his genes. And then we do have hopefully a nice woman on his side bringing her genes, and then as it is the dominant variant, they will have a 50-50 chance that they will pass it on to
heads or tails. He either passes on the faulty gene or
the normal one.
Yeah. But there are other modes of inheritance. So, for example, this is autosomal recessive. This is recessive, which means that the parents are not affected. They don't have any problems, but they each carry one faulty gene. But because it's a recessive gene, you have to have two faulty copies to have the problem. So this is a recessive form of lymphedema. And this means that because both parents are carriers, there is a 1 out of 4 or 25% risk that each child might be affected. And again, it doesn't matter if it's male or female, there is a 25% risk to any children that they may have. Yeah.
Okay, I think I got that one. It looks easy. And then how do we know, or how do you know which genes are important for our primary lymphedema patients?
So there's a number of different ways. So as a clinician, I will always ask about the family history. So this is a family. The squares and circles coloured in black are babies with lymphedema. The white is not affected, and you can see that there are 3 affected children all in the same generation. So the parents are not affected, but there are 3 out of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 children with lymphedema, with a lymphatic problem. So this is consistent with autosomal recessive, because it's horizontal transmission. The parents are not affected, and there's more than one sibling with this condition. So we know from the family history that this is recessive. So we can tell quite a lot from the family history. We can also tell by examining the patients really carefully. So when they come to the clinic, I will always measure their heads. I have a tape measure in my left hand because I need to look for microcephaly. And I always look in the eyes because in a particular condition called lymphedema distichiasis, you get these extra eyelashes, which are distichiasis, which grow from the inner eyelid and cause irritation to the eye. And we know that nearly everyone with lymphedema and with distichiasis have a mistake in the same gene, which is called FOXC2. So there are clues from the history, the clues from the family history, and there's clues from the examination as to which gene might be causing primary lymphedema.
So it's when you have a patient with swollen feet, you will always ask for additional visible or invisible symptoms. So small head or problems with eyelashes, or I guess problems with the stomach or something that will bring you then to different genes in the whole structure.
Correct. Yes. So there are often clues there that if you take a proper history and examination, you might be able to find. Yeah.
Okay. And is there a set of genes where you know so far that they are linked to primary lymphedema? So I know there is. So that's why I'm asking.
A lot of genes. So don't panic. Do not panic. But this is our classification of primary lymphedema. And so these are all different causes of lymphedema. And in the red, you can see the names of the genes. So there are many, many different genes presenting in different ways.
Okay.
So
yeah, that chart looks very complicated for the for me. But what I can see straight away is KIF11 marked as red. So our affected gene on the green part. So what do the different colors then mean?
So KIF11 is here in the green bit because this is primary lymphedema that presents at birth, congenital, and we've put it here so that people always think about KIF11 as well as Milroy disease, which is up here. So KIF11 presents with swelling of the feet, usually at birth, so it's in this section. KIF11, if you look at the blue section at the top right-hand corner, the blue section are syndromes that is conditions that have more where the lymphedema is just a small part of the problem, and so KIF11 is also listed in this table 2, which we can't see at the moment. So there are a number of genetic conditions that cause many other problems like intellectual disability, congenital heart disease, epilepsy, and so they're listed in the blue section.
Okay. And the red ones?
So the pink
the pink ones?
The pink ones are people, patients.
Systemic involvement. What?
Systemic involvement. Sadly, a small proportion of our patients, about 10%, have lymphatic problems internally. So they might have fluid on the lungs or in the tummy, or they might have fluid around the heart, or they might, when they're a baby in the womb, they may be swollen. So the pink relates to that group where the lymphatic problem is more complex.
Okay, and I can read that the purple one is then are those genes where will show up later onset, so over 1 year old?
That's correct, yes. So these are the late onset lymphedema. So many Many people are born with a weakness in the lymphatics, but do not present with swelling until late childhood, puberty, or even adulthood. So just because you're not born with lymphedema doesn't mean that you don't have a genetic cause for the lymphedema.
I think that's important for patients because not many of them, or many of them, show it later and not by birth. Even HIF 11 kids, when I now think about our own syndrome, they not only show by birth than the lymphedema. So yeah, that's quite interesting. And then we're missing the yellow boxes.
The yellow, much more complex. These people have one limb that's much longer, bigger than the other. They have birthmarks. So these are not so much the primary lymphedemas as the sort of vascular malformation section. Yeah.
Okay. So as a patient, I don't need to remember that chart, but it might help me to sort my gene in there if I already know it. Yeah, it helps the clinicians.
It helps the clinician to try and work out the genetic cause of the lymphedema. Yeah.
But for us, it is important to remember. So if I have swollen upper or lower limbs, then and in addition something else, then it may likely be a genetic reason for all that.
I agree. Yes, definitely.
I guess we have a good overview of the different types of genes now. So those who are visible by birth and later onset. Can you give us one example maybe of one syndrome and how you found it out?
So one of the most common causes of primary lymphedema is a condition called Milroy disease, which was described in 1892, so very, very, very long time ago. And this is a child with Milroy disease with the typical findings with swelling of the feet and these small upturned nails because of edema of the nail bed, swelling of the nail bed, and deep creases in the toes and these wide caliber veins. So by examining the patients, you can have a good idea of which gene might be causing the primary lymphedema. Not always, but sometimes.
Yeah, so that picture looks very familiar for me because that's how the feet of Paul looked like in the last years. And the nails.
Absolutely right. The feet in lymphedema associated with KIF 11 looks identical to Milroy, which is why it's also important to measure the head circumference, which is something we would always do. Yeah.
Okay. Yeah. So it's not an easy thing just by viewing the people to directly link it to one gene which fits to that specific type of lymphedema. So maybe that's a good end to come to session 2. And session 2 will be all about the genetic testing and the procedure which we as patients will need to run through if we decide to go for a genetic testing. Maybe can you describe what we as a patient need to do when we decide we would like to have a genetic testing? I assume that's a bit different country by country.
Yes, so genetic testing is now available in most countries, but in some countries it's more comprehensive testing than others. So in the UK we can test a patient for a number of genes, in fact 41 genes at the same time. We do a panel of genes, so even if I have got the wrong diagnosis clinically, I have a very good chance of finding the genetic cause on the testing. But this isn't available in every country in Europe, and the best way of accessing the test is to get referred either through a lymphedema clinic or to a clinical geneticist who can assess you or your child and decide on the appropriate testing for them.
So if I'm in one of those European countries where it is not as clear where to go, is there an option to do it privately, or where do I find those expert centers?
So I think most countries have private geneticists, so you could access a private geneticist, but of course the testing is expensive. It's not a cheap test.
Okay.
It's quite labour intensive through the analysis, so that's expensive. I think probably the best thing would be to look on the VASCERN website, the European Reference Network website, under the primary and paediatric lymphedema, where there is a list of expert centres in Europe. And I suspect that the best course of action would be to be referred to one of these centres, not just for the genetic assessment and testing, but also for the management of the lymphedema. So that hopefully will be a good resource for most people.
Yeah, thank you. And what can I expect then from, how does the testing itself work?
Yeah, so it's just a blood test. It's no more complex than that. It's a blood
simple
test.
As that.
Simple, but it's a blood test on the affected person, and then it's sent to the lab.
Okay, and how long does that how long does that take usually?
So in theory, if it was an emergency, they could probably get the result in 2 or 3 weeks. But in practice, because of lack of resources in most countries, most labs, certainly in the UK, it's taking up to 6 months for that result.
Okay, yeah, that fits to what we experienced. So it took us nearly 1 year, but we started with the normal testing with blood of Paul and also us as parents, and then it came back without any result, and that leads me to the next question. Is then when I receive the results, is that always clear and will bring me the answer, or?
So you're right, things have become more and more complex. We can now sequence the whole genome, so all the DNA, they can do it in less than a week, but the tricky bit is interpreting the results, and that is because we're all unique. We all have our own variants. I have 17,000 variants that hardly anybody in the world has, apart from probably my parents. And so it's sometimes difficult to know if a variant, a change in the gene, is causing a problem or not. So it's not uncommon to find a variant, what looks like it might be a mistake in the gene, but possibly is not a mistake. And sometimes we can't get to the bottom of that. So sometimes we are left with uncertainty. Yeah.
And in our meeting earlier, you said Paul was a good example for one of those weird results where you need to go in more detail. Why is that the case?
Did I say weird to you? That's
yeah. Strange. I think you used strange.
Yeah. So Paul has a mistake in KIF11, but we rely on looking at that mistake to see that it changes the amino acid and changes that protein. So you want to see that the fault or the variant in that gene is causing a change to the final product. with Paul, the variant doesn't change the amino acid, and so in theory it doesn't change the protein. But we know from extensive research previously on the same variant that it actually causes that protein to be shorter. It makes it stop sooner. So we know for sure that it is the cause of his problems, even though on paper it doesn't look like it is. So it can be complex.
Okay, you lost. To be honest, you lost me a minute ago, but that's exactly where the complexity in the genetics is for parents not easy to follow. But in my head, you do have a kind of database online where you put in all those figures you receive from a patient, and then blam, it says, oh, there's one person out there in the world where you have exactly the same variant on that level. Is that right? Is that how I can imagine it?
Several databases. There's databases of normal variation. There's databases with variants that cause disease. There are other databases that show you how that variant affects the protein. So yeah, so it's a complex process. The analysis is complex. Yes.
And so even if the results come back without any clear answer, it might not be the case that there is not a genetic reason for it. It's just, it can be the case that just nobody found it yet. So you will be the first one.
Absolutely. So we do not know all the genes that can cause lymphedema. So there are genes that we haven't yet found or recognized. And even if we know the gene, we are not so clever at always picking out the fault. So yeah, so it doesn't, sometimes we know from the family history that there's definitely genetic, but we cannot find the cause.
Yeah. Okay, I got it. And when we now think about the future of genetics, as you said, we don't know all of those genes yet. Do you personally think that there will be more in the future, and how will that help us as a patient?
So genetics is quite advancing very rapidly, and as I said, we can do whole genome sequencing in a very short time now. So the rate of gene discovery is quite fast at the moment. So the world will discover lots of new genes that can cause lymphedema, which is the first step. It's really helpful to understand why a particular gene is causing lymphedema, what the gene is, and then understanding the mechanism. Why is that? What effect does that gene have on the lymphatics? And then from there, maybe it will lead to better treatment.
Yeah, and more quality of life. That's what we are all looking for and wish for. That, yeah, maybe there will be a cure in the future. So better treatment, hopefully, we're looking for. And maybe as a summary, from your point of view, why is it beneficial for parents or caregivers to do a genetic testing if you have primary lymphedema?
Yeah. So it's always up to the patient or the parents to decide if they want genetic testing or not. Nobody is going to force them. It does help the clinician to know the underlying genetic cause. For example, if you knew that Paul had a mistaken KIF11, you may know that he's more at risk of having epilepsy, seizures. You would know that he might have tummy problems relating to the lymphatic problem. and that might be helped by diet. So by knowing the exact diagnosis, it does help the doctor and the parents to manage the child.
Mm-hmm. Absolutely agree.
Yeah.
Yeah, absolutely agree. So I think the medical side is one reason, and then also as parents, the psychological part of it is, I think, also very important to know that there is a reason for it. It's not your input on that child and your family situation or something. It's caused through a gene, and that helped me as a mom very much to calm down and not make myself responsible for behavior issues, etc. So I think we do have now the perfect start to support him in each category as much as possible. Yeah,
the other reason for doing it is because I know you have a little girl.
Yeah,
and
the family planning is a huge thing. Yeah,
because of the result, you knew that this was not inherited.
Yeah,
and so it's much safer to go ahead and have another baby, knowing that it's unlikely that they would have the same problems. It must have given you some reassurance about having another baby.
Yeah, for us having only one child, yes, and also then later on for Paul, just in case he would like to start with family planning, then also for him. So for both sides, for us and for him. Thank you very much. Thank you very much for your time, and I hope I was able to ask the most important questions from a patient point of view. If not, I know we do have the chat functionality available, and we will answer the questions live on the Rare Disease Day. So have a good afternoon, Sahar. Thank you.
I look forward to the questions.
Well, thank you very much to Sahar and Carina. I think they answered so many of the very, very important questions. We have already the first question, and it is, how often does it make sense to repeat a genetic testing, or do I need to accept it someday that there is no reason?
That's a very good question. A person's genetic makeup doesn't change, but the technology and the testing is getting better and better. So the only reason for repeating it is to look at genes that were not known about before. And although we are discovering new genes in lymphedema, it's probably only 1 every 2 years or so. So I think it would be worth leaving it a good number of years before retesting. But I think it is worth retesting, maybe after 6 to 10 years or something, just because we're learning more and more about the genetics, not because your genetics has changed. Yeah.
But how will you know? I mean, because if you can say that if you take a test and then can you see somewhere on the internet that there are new genes discovered and it would be worthwhile having another test, or how does that work?
So there's new genes discovered which are published in the medical literature, but then there's a sort of delay for it to become part of the panels that are tested. So there is a year or 2 or 3 years delay. So it would probably be safe just to leave it a few years before you test it, because even if there's one new gene, nobody's going to be able to test it initially, because it then has to become part of the service. And then your clinician, because all of you will be under a lymphedema therapist, hopefully they should know about the new genes that are being discovered.
And can you tell us a little bit about what happens with this material that you, the blood test? Then you do your genetic test, you get the results, and you find out what it is, or perhaps there isn't. But do they keep this material for later, or is it used for research, or how does that work?
It's always stored it's frozen and stored, so you could, in theory, just ask for the old sample to be reanalyzed. You don't, in theory, need a new blood test. Most places will store it. Nobody will use it for research without signed consent. So nobody will use it for anything other than diagnostic testing unless you've agreed to it and written, signed for that. And it's been explained to you. So I wouldn't worry about the sample being used for any other purpose.
And what is the future for genetic testing for primary lymphedema? Do you think there can be in the future some kind of medication based on this?
I hope so. Do you remember the yellow section of the chart that we showed? Those are patients with one leg that's much bigger, longer than the other, with birthmarks on that leg. And we know the genetic basis of a lot of those conditions, and there are already targeted treatments for those conditions. So there are treatments where you can reduce the growth of that leg and perhaps dampen down the birthmarks, which might be leaking lymph. So in that area, it's already helping. In primary lymphedema, not so much yet, but the aim is for better treatment. Yes, hopefully. We're a long way though.
So the next question is really about, do you think like a genetic test or the results from it can change the treatment plan? What could be changes in the treatment plan based on the results of such a test?
Yeah, it's mainly for surveillance more than anything. So, for example, if we have a patient with lymphedema with distichiasis, we know that some of them have a heart problem, some of them have a kidney problem, so we would always organise a heart scan and a kidney scan. Some patients with lymphedema have a problem with their immune system, so we may test their immune system and maybe give them some antibiotics to stop them getting infections. Most people are prone to infections anyway with lymphedema, but some people have a weakness of the immune system, so it would be important to know about that. So yeah, there are aspects of the management that would change depending on the diagnosis.
Exciting. And just to finish it off, I have another question is, so where in the world is there being done lots of research into the genetics of primary lymphedema? Is there somewhere there's like the holy grail of this, or are you all collaborating in the world, or how does that work?
So the Holy Grail is St. George's. No, I'm joking. No, there are a number of different centres working on it, and we do collaborate, and we have meetings, conferences where we learn about each other's work, and one person's discovery leads to further discoveries in another lab. So yeah, it's a small world, but there are a number of centres that have a huge interest in identifying the genetic cause and the mechanisms as well. Yeah. There is a few.
Great. Well, if we have no further questions, just finishing off, then I would personally like to thank Sahar and Carina for joining us today. It has been such a discovery into the world of genetics and primary lymphedema. And for everybody, please watch this again on YouTube when it's available, or share it with your clinicians or your fellow patients. Thank you.
Thank you.